Hello and welcome, everybody. This is Deborah Ness. I'm president of the National Partnership for Women and Families, and I'm talking with you today as a leader of the Campaign for Better Care. The National Partnership leads the Campaign for Better Care together with three partner organizations: Community Catalyst, the National Health Law Program, and the Leadership Conference on Civil and Human Rights. And before I do anything, I want to first say thank you for taking the time to join us and for your interest in hearing about two very exciting initiatives we're going to talk about today, the campaign and the Partnership for Patients, which are really both dedicated to transforming our healthcare system in a way that results in providing better care to the people we serve at a lower cost. So on that note, next slide, I'm going to start by giving you a sense of how this hour will go. I'm going to do a little bit of background and context on the campaign. We are privileged to have two extraordinary presenters with us today, both of whom have been pioneers and champions in the area of patient safety and patient-centered care, and have been working for years on trying to make our healthcare system more responsive, more sustainable, and more affordable. After their presentations, I will come back for just a couple minutes to talk about ways that the campaign would like to work with state legislators around the country, and then we are going to open it up for your questions and discussion. I have with me today in the room a number of members of our campaign team who will join in that discussion. And I would like to say just a couple things about logistics. Just so that everybody knows, this webinar is going to be recorded. That's so that we can put both the audio and the visual parts of this webinar on our website, and we plan to post it on our website in the next few days, and you'll be able to find it at www.campaignforbettercare, that's campaignforbettercare, one word, .org. And in order to ensure that we keep background noise to a minimum, we are going to keep all the phones muted until we get to the part of the agenda where we have discussion and Q&A. And at that point, we will give you all instructions on how to queue up for questions. So, next slide. So first, a little bit about the Campaign for Better Care, which now has a coalition with more than 150 national, state, and local allies from around the country. The campaign is actually dedicated to two goals. One is to really improve the way that health care is delivered, particularly for older adults, people with multiple chronic conditions, the most vulnerable populations, the folks who are the heaviest users and therefore incur the highest costs in the system, but also generally have the poorest outcomes. And our second goal is to reshape the healthcare system in ways that actually get us to better care and lower costs, and to care that is really much more responsive to what patients themselves say that they need. And we've done a lot of research on that topic, and I think you could fairly distill what we hear from patients over and over again down to three things: coordination, communication, and affordability. And we'll be talking more about those topics over the next hour. The reason we are calling this webinar to talk to you about the Partnership for Patients initiative is because that initiative is really a key opportunity for us to move forward on this agenda. It shares the same goals, and as you're about to hear, to get to better care and to safer care, it puts a heavy emphasis on better communication and coordination, especially with patients and family caregivers. Next slide. So Why is this all so important, and why do we, as a consumer organization, feel so much urgency about it? Well, just to give you a small sense of that urgency and the importance of this, we put a few facts up there on the screen. And first, we pulled out some facts on hospital-acquired infections, which are not the only things that can go wrong during a hospital stay, but one of the more troubling and problematic things that often goes wrong. And when I say often, I mean often. 1.7 million a year, at least 100,000 deaths. Some think that's a very conservative estimate, costing us as much as $25 billion a year. And equally important are the problems that occur when people get discharged from a hospital without the information or the right follow-up they need to get better and to keep themselves well. And it leads to a lot of preventable readmissions. And particularly in the older population, what we know is that 1 in 5 of older people with multiple chronic conditions gets readmitted to the hospital within 30 days of discharge. And these kinds of preventable readmissions are costing us roughly about $26 billion a year. And to give you just a little added flavor of how important this is when you think about state budgets, which everybody is so focused on these days. The older folks who are part of Medicaid, the dual eligibles, who are both eligible for Medicare and Medicaid, while they make up only 18% of Medicaid enrollees, they account for almost half of Medicaid spending. And so addressing these issues that are so costly, particularly in the older population, is a critical way of getting at excess costs in the system. Next slide. So today, we're going to primarily focus on this initiative, Partnership for Patients, and we think of it as helping to lead us to a solution that will help us to reduce Medicaid and Medicare expenditures, as well as healthcare spending more broadly, by improving care coordination and patient safety, in effect, saving money and lives. And with that, I'm going to hand it off to our first presenter. I'm going to introduce Dr. Lucian Leap, who is often referred to as the father of patient safety. Dr. Leap is an extraordinarily highly regarded professor at the Harvard School of Public Health. He has been an outspoken advocate for patients and for the kind of system-level changes we need to make in our healthcare system in order to prevent medical errors and improve the quality of patient care. He's one of the original founders of the National Patient Safety Foundation and the Massachusetts Coalition for the Prevention of Medical Error, and he served on the Institute of Medicine committees that led to the groundbreaking reports which really kicked off this movement for patient safety, To Err is Human in 1999 and Crossing the Quality Chasm in 2001. We really owe an enormous amount to Dr. Leap for shining the light on this important issue, one of the first people to do so and one of the most tireless leaders in this area. So Dr. Leap, I'm going to turn it over to you, and I thank you for being with us today.
Well, thank you, Deborah, and thank you all of you who have tuned in. I think it's a great opportunity to make some real improvement in the quality of care. I think most people first thought of patient safety when that Institute of Medicine report came out in 1999. It really was kind of a shot heard around the world because it said that 98,000 people a year were dying because of medical mistakes. But the second message was this isn't because of bad people, it's because of bad systems. Next slide, please. And if you look at it, it turns out that although there are literally millions of people being injured in hospitals, most of these are preventable. And the cause of the injury isn't carelessness or incompetence. That's the way we used to think about it. but it's because of bad systems. That is, things that make it possible to make mistakes, like, say, two medicines that have names that sound very similar or packaged in a similar way. And so the main thrust of that report, and really what we've been trying to do ever since, is that if you want to keep people from being hurt, you have to redesign your systems. You have to make it so it's hard for people to make a mistake and easy for them to do it right. Next slide, please. I think overall, in the, I guess now pushing almost 12 years since the Ireland report, we have to say it's been a great success story. Every hospital now has a safety program. Next. Hospital mortality has been going steadily down for the last 10 years. Now, that's not all due to safety, but certainly that's part of it. We've had a significant increase in funding from the government through the Agency for Health Research and Quality, and you'll hear from its administrator, Carolyn Clancy, shortly. Next. The National Quality Forum, which probably most of you have not heard of, most doctors haven't, as a matter of fact. It's not a governmental agency. It's a private organization that brings together all the stakeholders, people, doctors, nurses, hospitals, insurance companies, everybody. They have, for the last now 10 years, been working on and making available to us the information about safe practices. There's new ways we can give care, new practices that have been proven to make a difference, things that are possible for any hospital to do, and most of them really don't cost very much. And so part of what we've been trying to do is implement these kinds of safe practices. Next. We've had an interesting development that at all over the country, people have come together, usually at the state level, in coalitions, to talk about how they can work better together. We have one in Massachusetts, one in Virginia, Wisconsin, Maryland, many states. And these are people who come together, people from government, people from hospitals, people from professional organizations, to see how we can improve safety. And it's been a very impressive movement. Next. The Institute for Healthcare Improvement, again, a private, not-for-profit organization founded by Don Berwick, who is now the administrator of Medicare and Medicaid, has been a major contributor to this, training most of the people in America who have learned about quality improvement and safety have learned it through IHA courses or programs. And they had a very exciting 100,000 Lives campaign in which they got 3,000 hospitals to set out to try to implement 6 safe practices. And they not only achieved their goal of saving 100,000 lives, they exceeded it. They saved over 120,000 lives. Next. And finally, the Joint Commission, which is the organization that accredits hospitals, has put safety front and center in its efforts. And every year they announce new safety goals, which are really let's implement known safe practices. So there's been a tremendous amount going on. Next, please. And I want to just tell you 2 examples that I think are very exciting. The first is what happened in Michigan a few years ago. Peter Pronovost at Johns Hopkins had shown it was possible to eliminate infections from central lines. Central lines are little plastic catheters we stick in the vein and push it in towards the heart, used to draw blood and give medicines and so forth. It turns out that too many of them get infected, and sometimes those infections are fatal. And then also patients that have infections when they are on ventilators, when they're being breathed by a machine. Deborah talked about and showed you some information about how many people suffer and die from hospital-acquired infections every year. And it was a total cost, I think she said, of $25 billion a year. Well, two of the most serious are central line infections and ventilator-associated pneumonia. So Peter Pronovost, with the help of the Michigan Hospital Association, enlisted a bunch of hospitals to see if they could eliminate these infections. Next. And they showed that they were able, by putting in checklists and protocols, 68 hospitals were able to go for 6 months without a single central line infection or a single episode of ventilator-associated pneumonia. This was really very exciting. They had totally eliminated these 2 deadly infections for more than 6 months. Next, and they estimate, based on their previous experience, that in that 6 months alone, they saved over 1,500 lives. Next, reduced hospitalizations by 81,000 days. And next, saved $165 million. Now that is 2 conditions in 68 hospitals in one state. Multiply this by hundreds, and you can see how we could easily save more than that $25 billion. I think it's quite clear. This is just one example, but all kinds of complications and injuries from treatment are expensive. They're of course, the most serious thing is they harm people, but in addition, they cost a lot of money. And clearly, making health care safe is the best way to reduce health care costs, and we know how to do it. The next slide is another example, and this is the work of Atul Gawanda that many of you may be familiar with. These are results from an international program in which they implemented a surgical checklist, going through checking to make sure you have the right patient, you're operating on the right kidney, that you've got blood in the room, you've got the x-rays, all that sort of stuff, making sure everything's all set before and during surgery. And they showed that by implementing the surgical checklist, they were able to reduce surgical complications by over 40% and deaths by almost 50%. Dramatic impact. And now people are implementing this surgical checklist throughout the entire country. The American College of Surgeons has made it an objective, and many states are going for 100%. So these are a couple examples of some really impressive gains, and I think we really should be proud of what we accomplished. However, when you look at the overall information, next slide, and some recent studies, it's kind of discouraging. The Office of the Inspector General reported last fall of a review of Medicare patients, and they found that even now that 13.5% of these patients had serious adverse events. Adverse events are injuries caused by treatment, and that nearly half of those were preventable, but they estimate that as many as 180,000 Medicare patients are dying from these every year. Next, another study done in North Carolina looking at a new way to identify adverse events called a trigger tool, which is just a sophisticated way to do a record analysis, what it is. And they found numbers very similar. 15% of patients had serious adverse events, and nearly 2/3 of those are preventable. So this is really kind of discouraging. With all this work and some of these big hits, the fact that we still haven't really made a major impact overall. And so the obvious question is why is that with so much effort? Why don't we have more to show for it? Next. I think the thing that's been most interesting is that what we've learned is that making healthcare safe isn't just about putting in safe practices and filing reports and following protocols. Next slide. Next item. It's really much more about working together in teams, working in interprofessional teams, doctors, nurses, technicians, physician assistants, pharmacists, and so forth. And in order to do that, people really have to work well together and respect each other. Unfortunately, we don't teach teamwork in medical school, and so people have had to learn it on the job, if you will, and we've been rather slow at getting to it. Next. But teamwork is the secret of success for every industry that has succeeded in becoming safe. We all think of aviation when we think of something that's safe, and sure enough, it's true. When you get on an airplane, a commercial airliner, you're not very worried about dying because accidents are so incredibly rare. But one good example of teamwork is something I think most of you will remember, a picture we saw in the paper just about 2 years ago. Next. And this is U.S. Airways 1549, which Sully Sullenberger deftly landed in the Hudson River when both of his engines were disabled by birds. And here they are on the river, and all the people have gotten out, and they were subsequently lifted into boats, and not a life was lost. A few people had wet feet, but it was really pretty impressive. And what it was is he was the first to say not just that he was a brilliant pilot, he of course was, but it was teamwork because the co-pilot managed the plane while he was steering it down. The attendants got people ready. The attendants help people get out. Everything works like clockwork with a team that had never before ditched an airplane. But they knew what to do because they had trained as a team. And that's exactly what we need to do more of in medicine, not just for safety, but also for the everyday care of people with chronic disease that Deborah mentioned. We can do so much more to improve their care if we learn to work together. That's what we're after. Next. So what we're really saying is, in the last analysis, what we're trying to do in patient safety is change the culture. Our hospitals, our healthcare organizations haven't been oriented around safety, and so we're learning how to do this. And the first thing is what the Institute of Medicine said 12 years ago. It doesn't make sense to punish people for making errors, because the errors are not because they're bad, it's because of bad systems. We have to have a transparency. We have to have a situation where people can feel free to talk about their mistakes, and patients certainly have a right to know what's happening and what's going on. We need to be honest and upfront. We need to work together in teams. We need to be accountable not only to each other and to our institutions, but primarily, of course, to the patient. And we need to orient all our efforts around the patient. So what we're talking about is a lot more than just implementing a few safe practices. It's really undertaking a major culture change. Next. And what we're talking about today, the Campaign for Better Care, that's exactly what it's about. It's part of the larger initiative, the National Patient Safety Initiative, announced just a month or so ago by HHS, $1 billion to help hospitals and health organizations improve patient safety. A cornerstone of that are collaborative networks such as the Campaign for Better Care. And I think that the time has come for us to learn to work well together. It's time for all hospitals to get on board. It's time for all hospitals to do what some hospitals have shown is possible. Really, how can we do less? So I encourage you to use your influence to help hospitals really move ahead and doing what we now know to do and get on with the job at hand. Thanks very much.
Thank you, Dr. Leaf. That was wonderful and sobering and encouraging all at the same time. I am really very excited about our next speaker as well, Dr. Carolyn Clancy, who I've now known for quite a number of years because she has been serving as the director of the Agency for Healthcare Quality and Research, which we often refer to as AHRQ, since 2003, through both the administrations of President Bush and President Obama. And Dr. Clancy also happens to be an internist and a health services researcher herself. And if Dr. Leaf is viewed as the father of the patient safety movement, I often think of Carolyn Clancy as the quality mom, the person who has tirelessly been working within the federal government to raise the visibility, the priority, the urgency of these quality and safety issues and really put them on the map. She's an extraordinarily well-respected leader by every stakeholder group in the healthcare world, and her work really touches on every aspect of healthcare. And she has the experience as a practicing doc from the ground up to the inner workings of the public policy apparatus. So, Carolyn, with that, I know you're going to tell us more about the Partnership for Patients initiative itself.
Great. Well, thank you, Deborah. First, I'm really thrilled by the work of the campaign and thrilled to be here and delighted to be thought of as the quality mom. So I'll definitely take that. Next slide, please. So the Affordable Care Act, I think you've probably all heard a lot about fixing broken health insurance rules and helping to cover millions of previously uninsured Americans, a national tragedy, and we're making a difference right now. That's all really good news. What a lot of people have not heard about is all the ways the new law is also reducing costs while improving the experience of being a patient, being a caregiver, and being a healthcare provider. So the Partnership for Patients, Better Care, Lower Costs is one example of how the President is using provisions of the Affordable Care Act to make health care in America safer, more efficient, and less costly. Next. And I want to talk for a couple of minutes about what this means to real people. Because at the end of the day, I think that's certainly what moves healthcare professionals. It's what moves all of us, knowing that these statistics can be alarming, but when it's somebody you know, wow, it has a whole different impact. So the first person I want to talk to you about is Josie King. So you can see her picture here. She's really an adorable toddler, around 2 years old, I believe, who one night stumbled into a hot tub and got pretty badly burned. It was rushed to the hospital. I'm sure you can all imagine how frantic her family was. Her mom, Sorrel, is shown with her here. She went to Hopkins, and, of course, a very, very terrifying experience for the entire family. But then she was sailing along, doing well, close to discharge, and her mom said, you know, she just doesn't look right. And the nurses said, no, not to worry. She's about ready to go home. And essentially, her mother's concerns were dismissed. And, in fact, a few minutes later, they had to call what we call a code because her daughter had had a cardiac arrest, and they were unable to bring her back. So here she is, poised to go home. They're imagining getting her toys and stuff ready. Finally, their anxiety and anxious journey is over, and instead she dies. Very, very tragic incident for the whole family. And ultimately, her mom became a very, very important consumer leader and advocate for safer care, reinvested part of her settlement from the hospital and the institution in a Center for Safety at Hopkins. I was just up there yesterday, and they're doing phenomenal work and bringing others with them. Next slide. Now, Patrick Clancy is my dad. So a little over a year ago, I got a call at a national quality meeting, interestingly enough, from my stepmother, who was crying so hard I actually couldn't understand her for a few minutes. And it turned out my father had been admitted to the hospital coughing up blood, quite a bit of blood. He was on a blood thinner at the time, and there had been a miscommunication about changing his dose. Now, changing the dose is a very common thing to do to make sure people are in the right range. And the nurse said to my stepmother, give him 2. And I think it probably seemed self-evident to her that she meant 2 milligrams. My stepmother thought she meant 2 pills, and he got way, way, way out of range. So he was admitted to the hospital, and a completely avoidable admission if communication had been more effective. And I'm sure if you think about it, it's not surprising that when something like this happens, everybody in healthcare feels horrifically guilty. So, of course, he had a lot of really expensive tests. Thankfully, after about 3 days, he was discharged home. He didn't experience another harm in the hospital. His medication back on track, but a very, very scary experience for everyone. That's really what we're talking about in terms of readmissions, trying to prevent that. Next. And as Dr. Lee pointed out, these stories are not rare, and Deborah made the same point as well. The numbers she gave you for infection is about 1 out of every 20 patients in American hospitals is affected by a hospital-associated infection. Among chronically ill adults, about a little over 1 in 5 report a serious error in their care. You heard the statistics about Medicare beneficiaries. And if you think about it as leading causes of death, medical harm is number 4 in terms of leading causes of death in the U.S. And the good news is, although we've seen really important successes in the recent decade, and Dr. Leap, I think, described those very clearly, we still have pretty substantial variations in the quality of care. So we can't be confident yet that no matter where you land for care, it's going to be reliably safe and high quality. And in the same way, if any of us getting on an airplane would like to know that the same kind of teamwork that we saw by Dr. Sullenberger, excuse me, Captain Sullenberger, prevailed and nobody died. We'd like to think that about hospital care, and we know we can do much better, and we must. Next. So the focus of the Partnership for Patients is very direct. First is to keep patients from getting injured or sicker. The goal is by the end of 2013, preventable hospital-acquired conditions would decrease by 40% compared to 2010. Mind you, we think and we know from the experience of hospitals right now that a higher decrease than that is possible. But this is overall across the nation, and that would mean 1.8 million fewer injuries with more than 60,000 lives saved over the next 3 years. The second goal is to help patients heal without complication, and that by the end of 2013, preventable complications during a transition in care from one setting to another would be reduced by 20%. That is, hospital readmissions would be decreased by 20% compared to 2010. All told, this has the potential to save up to $35 billion over 3 years. I do just need to make a very brief comment that when we're making estimates about this, certainly from the government, we are by definition being very conservative, and my colleagues have had the lead on these numbers. So I'm going to tell you they're solid, and it's a low estimate. Next slide. So how does change happen? Don Berwick is fond of saying that, you know, safety didn't get safer on airplanes. We didn't do a better job because we just kept saying to pilots, please try to be safe. We actually put in place some proven strategies, teamwork, simulation, trying to anticipate the worst and knowing how we would react if we did. The same thing is happening in healthcare. We can and must apply many different types of incentives that are professional, because every single healthcare professional wants to do the best job possible, and incentives that essentially say, at a bare minimum, we're not going to pay more for extra care. And the real impact that is a result of harmful care, the real impact of that is that gets the green eye shade guys on board at hospitals so that they can make resources available, because they know in the long run they will save money and the country will save money and care will be more affordable. Doing this means we have to show successful alternatives, and we have to offer intensive supports. Getting to a place, providers want to work in teams. They want to have a culture of safety, and that's very, very different than how the vast majority were trained. So it's kind of learning new tricks, and at the same time, we know people can do that. Next slide. So at a national level, the vision is strong public leadership commitments. We want the boards of all partnership hospitals to publicly embrace the aims of the initiative and remove barriers to progress. I was very excited to be in Iowa just a couple of weeks ago. They became the first state where every hospital in that state has made a public commitment to this campaign. The second part is, as you're hearing from Dr. Leap and me, you can tell that some hospitals are further along in this journey than others. So we want to both raise the floor, that is to say, bring up hospitals that are relatively new to these ideas, at the same time saluting and applauding those on the leading edge to keep going and keep accelerating so that they can show us what's possible. And we have to put a very strong focus on smooth transitions between care settings. Those of you who have been discharged from the hospital yourself or have a friend or loved one will know it's often a fairly chaotic time. Stressful doesn't even begin to describe it, and we can do a much, much better job. Next. So what will be different about hospital care? Today, as Dr. Leap noted, almost every hospital has a patient safety program, and that's good news. But it's not completely clear, and probably not the case, that leadership regularly reviews the quality data. So what we'd like to see is that the boards of all hospitals understand that quality and safety are part of the bottom line and just as important as the financial information they've seen. Sometimes in response to our growing awareness about patient safety challenges, We've seen something of a hodgepodge of different programs, and as in any other aspect of life, that sometimes means the left hand doesn't know what the right hand is doing. And what we've seen from organizations that have been very successful is that they've got a portfolio of 10 to 12 improvement projects, areas where they've got a relentless focus on making care safe every time. Understandably, in the early phases, hospitals have been getting credit for participating, for setting up programs, for raising awareness, and that's a good thing, but as Dr. Lieb and the studies he cited showed, sometimes things get better and sometimes actually they don't. And what we're going to be transitioning to is major incentives to change outcomes. Increased transparency so that all of you know about when a hospital is participating and what the results have been. To date, there has been limited work on readmissions and not a clear strategy for care transitions. We're still in the building awareness phase there, and what we know is that with dedicated staff and programming around seamless care transitions, we can do a much, much better job. And frankly, today, patients and families are not an active part of the process. Sometimes you feel a little bit like being a passenger on that plane. The one person who's in charge is not you. And what we expect and know can happen is that instead hospitals can interface with the patient and family movement supported by the partnership, and we consider the Campaign for Better Care to be one of the leading partners in that effort. Next. So how do we do this? This all sounds great, doesn't it? First, we want to build on tremendous enthusiasm from the private sector. Second, we want to work with our partners to support the hard work of changing care delivery to make care safer. The Secretary Sebelius, announced up to $500 million available in financial support just this morning. So the timing of this webinar couldn't be better. There will be national-level content, tools, approaches available for everyone, and supports for every facility to take part in cooperative learning. How, the specifics of how this gets done at every hospital, probably going to look a little bit different, just as they did in the state of Michigan. We had the privilege of supporting that work, and the great thing was it worked in intensive care units in huge academic medical centers, and also in very tiny hospitals. Obviously, how it was implemented in those very different institutions is going to be different, and we have a lot to learn from both. I mentioned that we want to make sure that the leading edge keeps moving so that we can all sort of run it as fast as we can to catch up to them. So there will be an advanced participants network for ambitious organizations to tackle all causes of harm. And very importantly, we have to have engagement from patients, families, and of course, healthcare professionals. Measurement and data is going to be part of this, but if there's one thing we learned from the state of Michigan, it's that collecting a small amount of data and giving people regular feedback on how they're doing can make a dramatic and sustainable difference. In addition to that, there's ongoing work with communities to improve transitions between care settings. Next slide. So this slide, very, very tiny font, just lists some of our partners. Over 1,800 hospitals have publicly pledged to be part of this partnership. All told, there are over 4,300 partners. So we're very, very excited that people are excited about this. Next. The very important message is this is not just fancy rhetoric. We're not asking people to defy the laws of gravity. We already know that this improvement at this scale is possible, achievable, and has been done. I've listed a few examples here. 150 New Jersey healthcare facilities have reduced pressure ulcers or bed sores by 70%. Rhode Island has reported a dramatic decrease in those same central line infections. Ascension Health Sites, a large health system in the Midwest, participating in a perinatal safety initiative, have achieved groundbreaking birth trauma rates at or near zero. So we know that this is possible, and there are institutions out there to learn from. Next slide. So our ask for you is to join this partnership and sign a pledge of commitment. I've listed the website here, and I know it will be available from the campaign as well. Next. So I have to say that talking about tools often sounds a little abstract. My family tells me this all the time. So I wanted to just tell you about a couple that come from very well done leading edge research. We know they're valid. The Project RED, the Re-Engineered Discharge, this is a project that is actually using a nurse and a pharmacist to help people with discharge from the hospital, and they were able to reduce the rates dramatically in the first 30 days after hospital discharge. Now, at a time when many hospitals are still suffering from financial strains, what the team is testing now are computer avatars. When I first heard about this, I was a little concerned. I imagined my father being plopped in front of a video and falling asleep. Then I saw the program. It's really terrific. It's interactive. And I'm told that in many institutions, patients actually like the avatar named Louise better than real-life nurses because she's always in a good mood. Nobody calls her. She's not interrupted. It all works great. And you heard about the central line infection. Next. We also have at ARC and will be and have been making available through the campaign information from patients and families. It makes a huge difference if you ask questions. Sorrel King has really made a dramatic difference. Many patients, as Deb Ness reminds me a lot, and she's completely 1,000% right, the game changer in all of this has been activated consumers. Because I can tell you from the clinician side, they too want to make care safer, but you know, they're very, very careful people. And when a consumer says, why can't we go faster, suddenly we change from it's really important to be extremely careful and get it right to yes, we can do it right now. It's dramatic, exciting, and very, very important. So let me thank you for the opportunity to join you today.
Well, thank you, Carolyn. I think both you and Dr. Leap have certainly left me feeling inspired and energized, and I hope the same is true for our listeners. We have one last slide I'd like folks to look at before we open it up for questions. Just very quickly, we invited you all onto this call in the hopes that we could talk you into working with us and taking action. And as Carolyn said, the first thing we want everybody to do is to encourage hospitals in every community to sign the pledge. And if they've already signed the pledge, to thank their hospitals for signing the pledge. I think for every state legislator, we send a packet, and in that packet, we put the names of the hospitals and the hospital administrators in your districts and their phone numbers to make this as easy for you as possible. And our hope is that you will actually use that information to get in touch with your hospital administrators. Let them know that you know about this initiative, you know how important it is, and that you really want to support them and reinforce their work. Which takes me to the second point on here, which is creating visibility and more community awareness of this initiative. Just your getting involved, just your reaching out to the community, just you maybe going out to do an event with the local hospitals in your district could help raise community awareness of the importance of this initiative and the work that needs to be done. And we can help you do that if you're interested in doing it. We can help you also find constituents in your districts who have stories they can tell. There's nothing quite so powerful or interesting to the local media in your communities and those personal stories, and sort of combining a personal story with your presence and the hospitals can really help raise visibility and be good for us all around. And then finally, this is not just a one-time thing. This is not just about signing the pledge. The pledge is a pledge to achieve the goals that Carolyn laid out, to really reduce hospital errors and to really reduce readmissions, the things that are costing huge amounts of money and causing huge amounts of harm and pain and suffering to patients. So we would encourage you to go beyond just the initial contact with your hospitals and to get involved with them as they work to achieve these goals, and in particular to work with your constituents and the consumer groups in your community who we can help connect you with, in addition to the providers. And as Carolyn just said, patients and families can be a huge part of the solutions. Many of the hospitals and providers that have done the most creative work will tell you that the really highest leverage impetus for change they got was from the patients and family members who came up with ideas that they hadn't thought of and were really an inspiration to the whole team. And if you think about it, it makes sense. Who sees it all? Not other than the patient or the patient's family caregiver, in a way that no one part of the healthcare team ever sees. You know, the doc comes in, the nurse comes in, the aide comes in, but only the patient sees it all, and the patients are an incredible source of information and ideas for how we can do this better. And finally, I want to say that all of this is about improving care and saving money. We are extremely aware of the budget pressures that states are under, and we know that there's a lot of pressure right now to slash budgets, and Medicaid is one of the things that everybody's looking at. And in our mind, there's a sort of good way and a bad way to go about this. Yes, it's probably easiest to just slash budgets. And for sure, we know that's going to cause pain and harm. It means reducing services. It means cutting off beneficiaries. It means cutting payments to providers. Lots of hurt, lots of harm. And at the end of the day, you've done nothing to really solve the underlying problem. And while in the beginning it may affect mainly poor people, eventually it affects everybody because we're making the system harder and harder for anybody to afford. So the way we would like to see this done, the better way, we think, is through transforming the healthcare system, improving care in the kinds of ways that Dr. Leap and Dr. Clancy just talked about. As you could see, there are millions of dollars we can wring out of the system by just doing what it takes to provide safer and better care. And that is just one of many steps that we can use to lower costs and improve care at the same time. So with that, I want to stop, and we are going to open it up for questions and discussion. Our moderator is going to give us a few instructions on how to do that. Keith? Okay, I don't know where
Yes, ladies and gentlemen, if you do like to ask a question, you may do so by pressing the star key followed by the digit 1. Star 1 for questions, please. Please make sure that the mute function on your phone is turned off so the signal can be read by our equipment. Star 1. We'll pause a moment to assemble the queue.
All right, and while we're waiting, I'm actually going to ask a couple of questions myself, and I'm going to actually start with Dr. Leap. Dr. Leap, you've been at this for a very, very long time, and I'm wondering what makes you think right now is different. What creates this as a point in time that you're feeling so hopeful about?
Well, it's a good question, Deborah. I think there are several things. One is, you know, when the Institute of Medicine report came out, we all could see it was the thing to do, but we didn't really know how to do it. And in the intervening 10 years or so, we've developed a tremendous armamentarium. We have a lot of tools now. We have a lot of safe practices. We know a lot more about how to prevent infections, how to prevent medication errors. So we've got the tools in hand. And at the same time, I think everybody in healthcare has seen some successes. They've seen some things that work, and they realize that they can do a lot more. So I really have the feeling we're poised on the edge of a significant acceleration in our rate of improvement. Healthcare is incredibly complicated, and it gets worse every day, it seems. And so every new treatment, every new device, every new medication has its own potential for errors. And so we have a constant challenge, but I've never seen anything like the kind of engagement we now have. I think healthcare workers everywhere realize the problem's serious, and for the first time they can see some ways in which they can do something about it. So I really think we're going to see a lot of improvement in the next 5 years.
Great, thank you. Moderator, do we have any questions?
We do. We'll take our first question from Bill Brown.
Hi, I'm wondering where I can find out if my local hospital has already signed the pledge.
Okay. Yes, you can either go to the Campaign for Better Care website, which will direct you to the Government Partnership for Patients website, or you can go directly to the Partnership for Patients website, and that is at www.healthcare.gov/center/program/partnership.
Thank you.
Sure, and we will have this all posted on our website. Great, thank you. Are there other questions?
And we do have another question in the queue from Leo Suello.
Okay, Leo?
Hi, this is Leonardo Cuello from the National Health Law Program and the Campaign for Better Care. And my question is, for other people out there who are on the call out in a state or helping people out in states, how do they learn about these sort of new models that are a better way to improve care, and how do they start working to have those implemented in their state? What steps can they take?
Well, one of the places that folks can go is to the Innovation Center at the Department of Health and Human Services, and that information also is on our website, Leo, but there you will find a whole list of innovative resources, programs that are available. In addition, you can also go to the ARC website for information and tools. Carolyn, do you want to say how to reach that website?
Yes, so it's AHRQ, Apple Harry Queen Run .gov, and right on the front page there is a button for consumer information. And you will see information about podcasts if you're someone who learns by listening, and also information about tips for, say, using medicine safely, taking care of myself, a guide when I leave the hospital, and many, many more.
Another thing that I would add in here is that Dr. Clancy mentioned that today there was announced a $500 million program that's going to support hospitals in doing innovative things to improve the safety of care. But there's also another grant program that has been launched by the Innovation Center that is designed to help community-based organizations get involved with their hospitals in addressing the question of transitions of care and readmissions. And there's also a website you can go to get information about how to apply, what's required, how to apply for that kind of a grant. And you can go to the Campaign for Better Care website and find the very long URL for that. I won't try to read it on the phone, but we have a fact sheet called Community-Based Care Transitions Program, and you can directly get to the application guidelines from that. There's also a press release on the general HHS website that has information about where you can go to get the actual guidelines.
HHS.gov, G-O-V.
I also would like to say that for any state legislators or staff who would like assistance in getting involved in their communities, who would like to get connected with consumer groups in their communities, we would be very happy to work with you, and I would urge you to call us here at 202-986-2600 and ask for Courtney Shahan, S-H-A-H-A-N, or go to the info@campaignforbettercare.org email that you see on the screen right now or to the website. But we would be very pleased to work with all of you individually if you would like help in getting started or reaching out to folks in your community. Moderator, do we have any other questions?
We have no further questions in the queue at this time.
Okay. Do we have any other questions here in the room? Carolyn, I'm just going to ask you one last question.
Sure.
And that is similar to what I asked Dr. Leap. This is a unique time right now in terms of many factors converging to make this possible. I know there's a lot of excitement within the agency and different kinds of work going on. As you travel around and you talk to providers about this program, what kind of a reaction are you getting and what's your sense of whether or not there's any penetration of this excitement?
I think the penetration is very significant. First of all, many places I go to, people know about the campaign. Some of them are leading edge, some of them are just hearing about it, but I think Dr. Leap would agree that, you know, when the Institute of Medicine report first came out, there was a lot of debate about the number of people who died from medical harms. Now, numbers are good to debate, and it's always good to debate science, but it kind of missed the overarching point was that any number greater than 0 was too high. I haven't heard someone make noise about the numbers for several years. And I'll also say that once people get the bug and start, and I don't mean one of those bugs, killer bugs, I mean get the excitement, because it is infectious, about making change. You know, if you ever meet anyone from Michigan who was part of the original Keystone Project, well, they're ready to take on world hunger, peace, you know, big issues, because it's incredibly empowering. So part of the reason I think it's ready now is just because of all the work that's been going on in recent years. You know, bad news always seems to go viral and controversial stuff really fast. Solutions are different, but at the end of the day, I always come back to something a leader in critical care medicine said to me several years ago. He said, you know, we always knew about the infections in ICUs. And he didn't say it this directly, but pretty much between the lines was, we just thought they were inevitable. And he said, those results changed our ideas of what's possible. And there is nothing more exciting and empowering to healthcare professionals and organizations writ large than that idea, that you can do dramatically better. You can't buy it. You can't pay for it. It's just very, very empowering.
Well, that's a really nice story to share, Carolyn, and I think there is actually a companion story on the patient side of that, because when we first went out to talk to patients about these issues, we found that, you know, we'd ask them about safety and quality, and they'd say, you know, no, it's not a high priority for us. And as we began to dig deeper, it became clear it wasn't because they hadn't experienced errors or they didn't know family members who had it. It wasn't because they didn't have problems in getting the care that they needed. It was because they thought, well, this is just the way the system is. And they didn't have any idea that it could be different. And they had no picture of what different could look like.
Right.
And when we started talking about some of these models where people are really at the center of care and getting coordinated care, the light bulbs went off and folks said, sign me up. I want to be a part of this. So, anyway, it's sort of an encouraging compliment of both the provider and the patient inspiring each other. Any other? Kirsten Sloan?
Deborah, you and Dr. Clancy and Dr. Leap all talked about the impact on patients of this effort, but for state legislators and their staffs on the phone, there's also an impact on the cost of care as well.
Yes.
I was wondering if you all would touch on that slightly.
So from the federal side, the same financial incentives will be applied for the federal portion of Medicaid. I believe that in some states, the states have stepped up to do it for their state Medicaid programs, but I think it's something that bears a serious look-see, because this is a win-win. Better care and lower costs, wow, hard to beat that combination. There just isn't a lot you're going to find with the challenges facing states these days that really comes up to that level of potential.
And wouldn't you say that in some ways states can take some of this stuff even further and be very, very creative about how they go about it?
Oh, absolutely. I mean, one of the things I think Deborah and Dr. Leap and I and many others have learned is just as we know that all healthcare policy is an interesting intersection and mix of federal and state policies, there's always some states that are out on the leading edge. And what I find most fascinating, because I know that people from across the country have signed up to be part of this today, is that no state is doing everything right. Almost every state has areas where they are hitting it out of the park, and other areas, I'll just say not so much, where they can learn from other states. So I think there's huge opportunities, and I think the learning here, how'd you do that? I know it excites clinicians and hospital leaders and so forth, and I would think that it would excite legislators as well.
Great. All right, well, I think we are at the end of the time. Moderator, do you have anybody else in the queue?
We have nobody in the queue at this time.
Okay, so with that, I want to say thank you to everybody, and again, urge you to please contact us if you'd like to get involved. You can write us at info@Campaign for Better Care, or go directly to the website, or call us at the phone number on the screen, and we will work with you and try to provide every kind of support that we can. Thank you again.
Ladies and gentlemen, this does conclude today's discussion. We appreciate your participation. You may disconnect at this time.